Thank you guys very much for joining us. And then I just want to let my folks know in Ventura that we have the active speaker identified. So if you don't want to be the active speaker, mute yourself. Whoever is making noise on your side will show on the screen here for the audience. And it looks like, Tisha, you're the default. So when nobody's making noise, they get to see your face. So go ahead and smile. All right, great. Thanks to everyone. I just wanted to let them know what the room was experiencing so they could be aware. So thanks everyone for having us talk today. We'd love to tell you about what we're doing in Ventura County. I am Kate Cordell, co-founder of Opeeka, where we are looking to unify information to support care coordination. Now, you may have heard the term care collaboration. We're supporting care collaboration. You may have heard care coordination. Care coordination usually means sharing information for referral processes. So getting those referrals made, and then transferring that person in care from one co-served agency to another. Well, care collaboration is continuing to collaborate on that care after the referral so that you are continuing to communicate beyond the referral through the entire episode of care. So that's what we're looking to do in Ventura County. And we have here on the Zoom folks from Ventura County. I'm just going to go ahead and ask you guys to introduce yourself so that as you introduce yourself, your face will show on the screen.
Okay, so since my face is already showing, I guess I'll start. I'm Tisha Maeda, manager of ITSD projects. I'm part of the technical department for the Human Services Agency for the County of Ventura. David?
Hi, everybody. David Swanson, Hollinger, Senior Program Manager with Human Service Agency in County of Ventura. And sorry I'm not there in person this year, but excited to be here. Dave.
Hi, I'm Dave Roman. I'm the manager of the Electronic Health Record Systems for Ventura County's Behavioral Health, and also happy to be here. Jennifer.
Good morning. My name is Jennifer Dougherty, and I'm the Senior Manager in the Youth and Family Division for Ventura County Behavioral Health. Gabriella.
Good morning. My name is Gabriella Aguila, and I am Manager with Ventura County Behavioral Health.
Great. Thank you guys so much. So I'll just go ahead and advance the slides. I'm going to try to. Sorry, I guess it's not letting me advance. Getting kind of a dinging noise. I
have no idea.
Yeah, I don't know. So while we're fixing that, I can just go ahead and tell you a little bit about the agenda. Yep, so we're going to have some technical help here to help us advance the slides. And, oh, that button. Okay, got it. All right, there we go. All right, so we're going to talk a little bit about what the goals were of the project, what the current state is in terms of the ability to share information for care collaboration in Ventura County, what the hopeful future state is, what the benefits they would like to get out of this. And then we're going to go through the 7 steps that we are currently in the process of making in order to make this happen. And then there'll be opportunity for discussion, and then we have a post session where there'll be Q&A. Okay, so David and Jennifer, go ahead.
Okay, good morning again. So what this slide really illustrates is, again, a current state and future state, what we're hoping to go, assuming we're able to work with Opeeka, which we're still, I have to acknowledge, still in process of getting all those approvals, but really hoping this occurs because the aspirational future state is just wonderful and it'll be so helpful for the youth and families we serve. So on the left, you see that circle that shows, it shows a youth, and it shows them connected to a variety of systems. Each of the adults in the little pictographic are representative of different systems that we're all very familiar with. And you see it includes the school, probation, child welfare, managed care, regional center, and the mental health plan. And each one of those, if you could see, we know has different types of ways of entering the system, different assessment requirements. Families really forced to navigate complicated different systems that are not necessarily always aligned, and being able to speak with each other on behalf of the child. And we know that, especially with acuity going up and coming off of the pandemic, that we have youth that could very well be attached to every one of those systems. And we really want to be able to talk to each other and share data so that we can more effectively serve that youth and the family, and therefore have better outcomes. But our current state is, has some barriers to allowing that to happen, despite our best efforts, because in County of Ventura, we think we have really great relationships with agency partners, but we don't have a system in place. So we have a lot of separate systems doing their best, but it's still very separate. And so I'll pass it over to David Swanson Hollinger to talk about what we're trying to get to with this system.
Great, thanks, Jennifer. And as if you look over to the right, that smaller circle with the child, and I also want to say child in the context of their family in the center, that really is consistent with our overall work that I know you're probably talking about in all 3 days of the conference, around a much more integrated approach in all of our work with children and their families, and with data sharing and coordination is really critical to that. So what we're really looking at and excited about moving forward here with Kate and her team is the opportunity for better integration, a more streamlined, coordinated approach to information sharing, and then the use of that information to better support children and in their families. And as this obviously aligns with our approaches around child and family teaming with system of care work through AB 2083. And just want to note, you'll see those 6 partners on there. Those are very intentional. Those are, for our county, those are the 5 mandated partners for AB 2083 system of care work, as well as healthcare, which has been in Ventura is an additional partner as part of our interagency leadership team. So, knowing that there are many other partners outside of that, but from an agency perspective, those are the key partners. And as you will learn, you'll see that acronym PCIS, PCIS, Person-Centered Intelligence Solution. As we go forward, we'll dig in and talk more about what that looks like. And I will pass, I think.
Great, thank you. Yeah, go ahead.
Go ahead, Kate.
I was just going to say, on this next slide, we begin to break that down, operationalize how that's going to happen. It's really easy to draw a diagram and, and say this is what we want and what we hope for, but how do we operationalize that? How do we get from here to there? And we do it by catching one fish at a time, by not boiling the ocean. Anytime we try to do a project where we boil the ocean, we want to get all those partners in the room and agree on something, it's going to take a very long time if it's going to be successful at all. So we're starting in Ventura County with mental health and child welfare as the beachheads of this process. And you can see here on the screen that we are going to connect these 2 to begin with. And then, I'll pass it back to you, Jennifer and David.
I was just going to make a comment on that other slide for behavioral health folks. It also aligns with our no wrong door approach through CalAIM of allowing families to come in where they need to come in if they are need to come into any of our systems, but then the systems do the work behind the scenes and to enable communication and care for that child. So just wanted to put that in there because we're all very involved with CalAIM as well.
Thank you.
So moving on to this slide, yes, this is just really showing, as Kate laid out, we're starting with our 2 systems. Again, we're very fortunate, long-standing relationship and previous data sharing agreements, which will be spoken to a little bit later. But I did want to highlight that also here in behavioral health, we would like to be able to, or our plan will be to use this system not just for our shared clients with child welfare, but to use the Opeeka Pieces system for all the youth in our behavioral health system. So we think this is going to just have a lot of efficacy for our clinicians, for our clients, program managers, because the level of assessment reports that are available to inform treatment and programming are vast. And so we really feel like we could benefit our whole system in behavioral health, although we will have our shared clients with child welfare, but we on the clinical behavioral health side really expect to see quite a vast impact on our whole system.
Great.
Yeah, just to add to that, you can see child welfare as a subset, and I think it also aligns with again that broader perspective. Our children and families come in and out of contact with the various systems, so I think that allows for some of that flexibility. And I do have to note, thank you, Kate, for noting the beachhead approach. I think you said, and as you know in Ventura, as you can see from our backgrounds, we like our beaches.
Absolutely. I can't wait to visit.
Okay,
So
hello.
Gabriella, yep.
Yes, thank you. So this is the current state of how we are currently sharing CANS information in Ventura County. So we've been doing, as a lot of you have also, completing the CANS in Ventura County since 2018. Now we developed our very own Ventura County CANS because we wanted to ensure that we had a vast amount of data, to share with our agencies, partnering agencies, and also that we could track clients' progress as they receive services in our system. So our Ventura County CANS has an age range of 0 to 21. So the way it works now is our clinicians complete the CANS. That CANS is entered directly into our electronic health record. And this speaks to the partnership with our, with the CFS, since we allowed restricted access to our electronic health record of our CFS partners. We designated a few staff that can go into our electronic health record and pull CANs as they attend CFTMs or if they want to see the client's progress. And we'll get more into that, but that system is a little complicated and inefficient and very time consuming. And also, so once the clinician completes the CANs, the information is submitted to Department of Healthcare Services. We're also learning that we're cleaning up a lot there's errors. Sometimes there's errors in CANs. Multiple CANs are complete, or multiple intakes are complete, or multiple discharges, and we're having to clean up that data by hand, which is very, very time consuming. So this is our current state for CANs in our county.
And here we have the future state. David and Jennifer, you'll see pieces in the middle around the number 5. That's going to be kind of the hub in the spoke and wheel approach here. David and Jennifer?
Yes, thank you, Kate. Yes, this future state, again, is something that is very exciting to us on a number of levels. And so I'll walk through the diagram from the behavioral health perspective. This really shows the technical process of how the data is going to move through the system. So future state would be, again, clinician completes the CANs. It is directly into our electronic health record. And then it is transferred into pieces from there. And then the clinician has the opportunity to go into pieces and to access that data and the various reporting and assessment features, of which there are so many. And then that can be used directly in treatment with the family to inform treatment planning, and also to share progress or continued areas of growth. So to have that feedback loop, I mean, myself having been a clinician, that would have been so fabulous to have that additional information set to share back with the family. So the clinician, as I said, can access the information. Meanwhile, the information in pieces is also going through a data cleansing process, which again sounds so fabulous, as Gabriella indicated. Right now, that is all happening by hand, taking a lot of time and effort in correcting errors that might be found and whatnot. To have the system be able to do some of that data cleansing for us and then alert us when there's problems, then we can attend to those. And then the pieces system will then directly be able to share that information with Department of Healthcare Services and give them timely and accurate CANS data. And again, we're just very excited about that process. Going back down to the pieces, and I know David will speak to this, once the information is in there, then child welfare then also has access to it. So again, just making a more fluid, easily accessible way of us to share information with our agency partners.
So just so to build on that, as Jennifer just said, our staff will have access to that information, and kind of from an operational standpoint, we're very proud in our county that for a number of years now we have done universal access to full mental health assessment for all children entering the child welfare system by behavioral health. So there's no screening process. There's automatic assessment and at least short-term treatment, which means every child coming in with an open case with their family does have a full assessment, which includes the CANS. And so this will really help us in our initial work with families to do both treatment and case planning with those families, and help us with those initial teaming processes through the child and family team process. So we're very excited about the opportunity to have more access to that data. The other piece that is hopeful here, and this is kind of before I get to the gray top box, we also right now with the CANS, Behavioral Health does the CANS on all of those children touched by child welfare with open, especially mental health cases, but we do have a subset of our children that are not in mental health services. And we're in the process of putting together a contract outside of behavioral health for completion of the CANS. The hope will be that we will be able to have that data sharing across CARES into pieces going forward, and allow for that sharing across our systems with behavioral health, because a lot of these children may come in and out of especially mental health services. Ultimately, what we're hoping is that this will then tie to that top gray box, and I think there's some discussions going on with CDSS about this, to potentially allow for data input into CARES. Right now, for those CANS assessments that behavioral health is doing for child welfare, they're inputting it, it's going into their system, and then it will go into Opeeka or into pieces, but we still have to separately enter it into CARES. And so it's essentially double data entry on the same information. And actually, in our case, it's a subset, because there's the smaller, shorter version of the CANS that child welfare enters into their system, as opposed to the more robust version, which we love, that behavioral health does. And so essentially it's duplication of work that isn't best serving anything. And so we're hoping this will really allow for some streamlined processes around data entry going forward as well.
Great.
Next slide.
Yeah. And even though we're talking about the CANS here, the hope is that, again, the CANS is the starting point, that really pieces is data agnostic, and anything can be shared about a person and a family. And David and Jennifer, here are some of the benefits.
Yes. So as we've been discussing the benefits, this really highlights them. The first one being that there's a single and secure CANS data repository accessible by all partners. And you'll see what we're hoping our future state to be, but right now by the partners of behavioral health and Human Services Agency. Second excellent benefit is to have the in-depth CANS analysis by client, by clinical staff, by clinics, eliminating that black hole of CANS entry. Right now, we put the information into the system, but this would allow that feedback loop, and to have that rich data in the CANS be translated into accessible reporting that can be used, again, directly by clinical staff, program managers, et cetera, to really continue to inform us about the treatment planning and progress and continued needs of our client population. And number 3 is, again, such a big benefit is Opeeka being able to submit our cleansed cans data to Department of Healthcare Services, eliminating, as Gabriela had indicated, the high labor-intensive process from operations. We know that resources are limited, and so we want to be able to use our clinical teams and managers to provide the services, not doing kind of hand counting data submissions. So to have Opeeka do this on our behalf will be a huge efficiency and benefit to our entire system.
And then the last, I think, is consistent with what I talked about in the last slide, just the opportunity to share data back and forth between pieces and cares.
Great. And I just, we had a 10-minute alarm, so just so you guys know. Step 1 in the process is the MOU. David, Jennifer, and Gabriela.
Yeah, thank you. So just a little bit of history as to how we've been sharing, information with, with HSA. So going back to the implementation of KDA, something that our agencies did was to formalize and standardize findings and orders, a paragraph in the findings and orders that allowed us to freely speak, with HSA. And as David mentioned, since, we currently assess all youth coming into dependency, CFS automatically sends us findings and orders of all youth coming into their system. So it really streamlines and facilitates that communication between both agencies.
And step 2 is defining the sharing process. There are a number of steps here for your benefit, but shall I move to the diagram? Gabriela, David, and Jennifer.
Okay, so great. So this one, and I just really want to highlight that this one came out of the CANS CFTM pilot that we worked with, with our partnering agencies. We really wanted to ensure, first of all, that all 3 agencies, probation, HSA, and behavioral health, were very well versed and understood CFTMs and CANs. And we're in the process of training all the different agencies. And again, just starting with the basics of making sure all 3 agencies understand that process. And then we came up with just a very streamlined process of how we would share the CANs, United CFTM, and feel free to jump in, Tish. But it really starts with the social worker. Again, when they open the case, the case is assigned. It's assigned to a CFTM facilitator. They give behavioral health, and they send us an alert that a CFTM has been scheduled. Then we alert the treating clinician that a CFTM has been scheduled to make sure the CANS is completed. We do complete the CANS with all the assessments. So we want to make sure that is completed, and then come prepared to share that with at the CFTM. On the CS side, the social workers make sure that the families are informed of what the CANS what the CANS really is. And at the CFTM, again, the facilitator also informs the team of what the CANS is and guides the conversation as to what are the needs and strengths and actions, next steps, actions, action plan for the family.
The only thing I'd like to mention here is that along with the workflow evaluation, when we were meeting with behavioral health on how we could use Opeeka PCIS, we detailed out this workflow, we detailed out user steps. We really evaluated how we could collaborate using this PCIS system. So some of the decisions that we've made, you're going to get to see in the next few slides.
Great, thank you. Yeah, so they've done a lot of work, and we've done a lot of work together in preparation. So the system isn't fully implemented yet. We're in the process of getting ready to do that. But you can see there's a lot of upfront work to really understand how it's going to work. And the next step is to define what should be shared and when. And so we figured in the step 2 was just how that workflow is going to work, but what exactly is going to be shared. And we're talking about the CANs in this case. So as I think David mentioned earlier, the behavioral health CANs version is different from the HSA or child welfare version. And so the next step was doing a crosswalk between the two and finding out which elements and which questions were the same and should be shared, and which ones couldn't be shared, and then which ones needed to be set as confidential and could only be shared with a release. And so Pieces is flexible to allow all of this type of sharing, restricting right down to a particular data element, and I'll show you how that works in the subsequent steps. So step 4 then is in Pieces to set up what's called a caring circle. So in Pieces, behavioral health has their own agency and their roster of all 3,000 children and youth, and child welfare and HSA has a separate agency with their 400 or 500 youth that they're serving. So not everything is shared. You've got a larger group of folks in behavioral health than you do in child welfare. And so what happens in Pieces is when kiddos are enrolled in a collaboration that includes both child welfare and behavioral health, we'll establish a caring circle. So that's set up in the system where you turn that sharing on and you share what's assigned in that collaboration. So very specific, saying we're not sharing the entire record, we're only sharing, in this case, the CANs. But it goes further than that. Within the CANs that behavioral health has, they will mark specific items as not shareable. So on the child welfare side and the HSA side, when they log in, they won't see those elements. So on the left, you see what behavioral health sees, and on the right, you'll see what child welfare HSA logs in and sees. They simply don't see the questions that are marked with the little don't share symbol. So when we calibrate the CANs the first time, we mark which questions shouldn't be shared, and then we identify which populations will share information so that only kiddos enrolled in that collaboration will have that information shared. Final thoughts, team?
Well, we're not quite there yet, but we're really hoping to be able to utilize Opeeka, utilize the Pieces system. I think it'd be tremendously beneficial for the youth and the families that we serve both jointly, and then behavioral health, those that we serve on our own, but just to enhance that continued cross-system collaboration with initially HSA, but building it out towards our additional agency partners. I just feel like we'll bring in just a new chapter of data sharing and collaboration with all of our related and partner agencies to the benefit of the youth and the families we serve.
And lastly, just as a non-data person, I've really appreciated the way Kate and her team have really tried to make this user-friendly for us that get scared when they start talking technology. So I think it really will be exciting and effective and beneficial to our families.
Great. I think this is so exciting. You guys are doing a wonderful job, paving the road and the path, and I look forward to presenting next year on our progress. So the question I'll repeat is, do you have a go live date for the system, and what is the expenditures? So what is I'll let Ventura County cover, what is our go live date anticipated to be?
Yeah, I'll take that one. The go live date, we estimate that we can have this launched within 6 months of the start of the project. The start date has not been determined because of the the arduous purchasing process, let's just call it. Every purchase goes through many different reviews and things, but we believe that with the help of Opeeka, once we have the green light, we can be up and running within 6 months.
Yep. And so on a technology side, we usually take about 30 days per system integration. So right now that we're talking at Ventura County is one system integration with NetSmart. And so from a technological standpoint, it'll take us about 30 days. The 6 month is a good buffer in case there is any other, red tape with that. There could be some questions from Ventura County IT about the way that, things are integrated. And so it can slow the process down a little bit. But from a technology standpoint, it's about 30 days per system. So if you're doing 2 systems, you can think 60 days. If you're integrating 3 different electronic record systems, you can think 90 days. That's about the time. And in terms of cost, Ventura County being the first to go, got a deep discount to be a leader. They are paying $95,000 on an annual recurring revenue for the system. So it's under $100,000 for the behavioral health and child welfare, for the behavioral health piece. And then as we loop in child welfare, folks to come online, I believe they have some custom reports, and that is another $24,000. So in total, you're looking at $120,000 annual for that system, which I think is really reasonable. Yep.
Well, and just chiming in with that, we haven't calculated it, but when we think of all the hours spent with data cleanup and the attention to that, we think there's a big cost savings to us, and so having the Opeeka as an additional cost, we think we're really benefiting from that in terms of efficiencies.
Yeah, I will definitely second that, the amount of time we're going to save in documentation and sharing and phone calls will more than pay for that.
I have a couple of different questions. One of them is this it sounds like Opeeka's intermediary type of system that kind of helps existing systems connect, sort of similar to Traverse, or is it a system that's pulling data out of existing systems and kind of reconfiguring the way it looks like Tableau?
So I can take that.
Okay, good.
Yeah. So it is a combination. It will integrate data into what's called a master patient index or master client index from multiple systems using an algorithm that's been developed over the years that's used throughout California, mental health, for the MHSOAC, et cetera, to merge and link the people from the co-served programs that they exist in. But then it augments that data with additional questionnaires that can be emailed or texted to families to answer. So if your electronic record system isn't flexible enough to add additional questions that you may want to track on those families, you can do it in our system. And then our system will push that data back in any format you want, whether that be as structured data, as an image, or as a PDF linked back to your record of authority.
Perfect. I guess the other question I had is that this is primarily focused on CANS data, but is there an ability to expand it for like PSC 35? Because it seemed like you were talking earlier about the ability to export the CANS data to the state through their reporting portal.
Yeah.
Could we do the same thing with PSC 35 data?
Yes.
Okay, perfect.
So just for folks, there was a question about acronyms. CANS stands for Child, Adolescent Needs and Strengths. It's a requirement for both child welfare and behavioral health in California to complete it. Different versions, unfortunately, slightly, although many of the questions overlap. And then the PSC 35 is the pediatric symptom checklist with 35 questions that's required by the Department of Healthcare Services for behavioral health. We are completely data agnostic. If you wanted to ask a family what kind of breakfast they feed their children, we could do that as well. So it doesn't matter what you want to do. You calibrate that question in our system like you would in, say, Qualtrics, SurveyMonkey, RedCap, and then that question is available to collect. It's as simple as that. You can calibrate questions and have them ready to go, texted and emailed to your families the next day.
More about the cost. does that include unlimited licenses, or is that a number of licenses? And then also, if you do want to add on the additional documents, would that also be like a la carte add-ons?
Sure, so I'll take that question. So our pricing is based on a per member or per patient per month or per year. So if you're a small agency or small county, you're going to pay less than a large one. So we want to make sure that it's, in that sense, affordable. For that cost, if you add, the pricing starts out with you having 200 data elements. So figure each question and answer, that's a data element. So if you go beyond 200, you can purchase a larger license per patient or per person in increments. So we can just meet you where you are as far as what your data needs are. So we have an annual subscription fee. We have an implementation fee. And we serve organizations as small as women's shelters with just serving 50 people or 100 people in a year, and conversations with large payers serving hundreds of thousands. So our software is for any organization of any size. And some even use Pieces as a standalone solution where they don't even use any other software. We don't do billing, though, however.
Follow-up question, are those active users per month, or is it into perpetuity, they've been in the system, and so you have to continue to pay for them?
No, it's just active. So for example, when we work with a payer, one of the big questions they had is, well, we don't want to pay for an eligible member that has zero activity, zero claims, use of the healthcare system. And the answer is no, you wouldn't pay for those folks.
But we can take all the historic data because
Yep.
it has a lot of good information to learn from in your data dashboards. So there's a whole dashboarding system, so you can look at all your historical outcomes across any of those data elements. And we really do encourage you to put in your historic data because that will inform how you're doing currently if you compare to the, but we don't charge for users because we want as many people to collaborate around the family as possible. The charge is really based on the number of people in care.
Hi, I had another question over here. So there was content around reports being able to go back to the clinician around the cans. Are those reports developed in some kind of an outcome measure or level of care tool? How's that reporting looking?
Yeah, we have a variety of reports, which I think was mentioned several times by Jennifer. Maybe Jennifer, if you could step in and say and let us know what it is you think is valuable about the reports that are available in Pieces.
The question is what?
Oh, the question, I'm sorry, I didn't repeat the question. Yeah, the
will be
question is,
valuable?
the question is what kinds of reports are in Pieces around the child adolescent needs and strengths and why and how will they be valuable?
Well, I have to admit, not being abreast of all the reports that are available with Pieces, but I do remember, and Kate, you'll have to help me. I mean, I have to be honest, everything that Kate was sharing with us, I thought, that has a place in our system. That has a place in our system. There was, I believe, a level of care report, which would be hugely helpful because we don't have a robust system for that, for our throughput. But there was also just various progress reports as well, client progress in treatment. There was also, I believe, reports showing you could plug in kind of like clients and what treatment and planning worked for one client. And if they have like symptoms and situations, then you could look that up and then kind of replicate and see what then would be helpful for your current client that might be in a similar situation. Those are the ones that come to mind, but I know there was also, in addition to the reports, there was also reminders, the ability to set reminders for staff. It's time to complete the cans, it's time to do the treatment planning, things of that sort, just these automatic reminders pushed out to staff to, because we know they have a breadth and depth of information they're trying to accomplish and get through, attend to their clients and attend to the many requirements that they have, and so to have those automatic reminders for them as they log onto the system would be very helpful as well.
Thanks. And I'll just add to that and say that there's a number of standard reports that are there, including a client story map that maps out all of the circumstances, including cultural, spiritual, tribal associations, opinions, satisfaction, symptoms, needs, skills, strengths, traumatic experiences, past behaviors. That's all mapped so that you can quickly see and remember the circumstances of the person you're serving. Because if you've got a large caseload, it's really hard to remember, even though they've told you all those details of their story. So that's a really quick way to see when somebody walks through the door and remind yourself so that you're cognizant of their story and you're sensitive to that. Also, we have family reports that we had 200 stakeholders engaged around the state of California to help develop that include flowers that sprout with a watering can to share with families what it is they're working on and what's being watered and what's flowering. So there's just a number of standard reports in there, and then we also have the ability to create custom reports. So custom reports as well in any format you want.
Thank you. And just one more question. Was there a reason, or you guys showed that there were a few questions or domains on the cans that you did not allow to be shared to child welfare? Can you say maybe what some of those were and why? Sorry for the hard question.
Did you guys hear that? No? The question was, why is not the entire child adolescent needs and strengths shared between behavioral health and child welfare HSA? Is there a reason why you don't share parts of the cans between the two organizations?
I can definitely answer that question. So the only challenge, we have is not being able to share the substance use information per 42 CFR Part 2 regulations. And we know the state, provides, some guidance as to how to share this information, but we're still, trying to work out, that part. But that is the only, we share all the cans except for the substance abuse information, which you figure child welfare probably already knows, and that might be, the reason why the youth are in the system. So we're still working on that piece.
Yeah, that's built into the state guidance around data sharing between our two systems and probation as well, for that matter. I think I did reference the fact that there, in Kate said as well, there are two different sets of CANs requirements. Between behavioral health has one set of requirements and child welfare the other. Child welfare requirement is a CANS 50 is what it's called, but it's fewer questions than what our behavioral health department is doing, and so that may have been part of the answer to that. What is entered into the child welfare data entry system, the new electronic health record, is just the subset of all of our questions we're doing in Ventura that are applicable to child welfare. But we are looking at everything we're allowed to see except for the substance use information.
I think you answered them all out.
Yeah, did I? Yeah, is that all the questions? They're really good questions.
Yeah.
Any other thoughts, Ventura County? I know we cut a little short. We have some extra time here. If there was anything you didn't get to say earlier.
Kate, I'll throw something out just because I know it's something I think I asked you when we first met, and before this webinar, before this presentation, I actually came off a call locally around work in Ventura County to create a community information exchange, which is being led by our healthcare agency, and both the mechanism for it and eventually the technology for it, similar to what San Diego County is doing. And I think I asked you, how does Opeeka and Pieces potentially interface with other kinds of data sharing platforms and things that I know different counties are looking at, across their systems or may already exist?
Yeah, so I know that other counties are looking at things for referrals, such as like Unite Us or Nine Patch or Julota, and there was another one, Now Pow, Aunt Bertha. So that's for referrals. So we're post-referral, so we actually complement with those, and we are working with right now with 9Patch, I don't know if you're familiar with them, they're like a Unite Us, to figure out how to integrate so that we can close the loop post-referral, and they can be the care coordination and we can be the care collaboration piece. And we're looking to do that with Sac Valley MedShare around Sacramento County. And that is TBD, to be determined, but we definitely we believe it's going to take a village. We're very collaborative, and we think that all of these technologies need to work together. And so we're very, very open to that, working with any other technology that is in use. Because we are completely data agnostic to the extent that the data must be about a person or a family. We cannot capture and do not capture any information about facilities, or anything that's not about a person. We are person questions and answers with answers that change over time. So we're a longitudinal tracking of people and clients' journeys through care and across care agencies within a system of care. So that all being said, there's a lot of different moving parts in there, and we are able to pass information to and from those different systems. And so with 9Patch, there might be a need for a referral that would come up in our system because, as Jennifer mentioned, there are a lot of alerts. So when a question or a combination of questions gets answered in a particular way, it'll generate an alert that a referral is needed as you have calibrated the system. That can then get sent to Unite Us or 9Patch or one of those systems. They can manage the referral process and close the loop to make sure that referral process has been completed. And then, should that agency want to receive additional information about the consumer or the client, that request can come back into our system and that information can be shared. We can share via secure email of reports as well in an automated fashion. We do that for Lutheran Social Services, one of our clients, by sharing secure emailed reports to people in the care circle. So we have a lot of different ways to share information in as much of an automated fashion as possible, and we want to work with all the different technologies that support the system of care.